So let's talk about principle 3.1.1, page 7. And again, it's to address the change of the concentration to the 10 milligram per mil. Some of you asked me this, so here it is. Methadone will be dispensed as is, as 10 milligram per mil. The cherry flavor, commercially available product, we will not be changing anything in that. So the decision has been made. The methadose or methadone 10 milligram per mil commercially available product will be dispensed as is. And only the commercial product will be dispensed. With a commercial product having a DIN number, we're hoping that PharmaNet will come through and we will have the pins removed. How are they going to do that? I don't know, but this is the word out there, is that we're going to be able to use the DIN for our entries and claims. I think this is one of the chronic issues that we've all dealt with. If a prescription comes and it's not clear if it's for maintenance or for pain, but there is one answer here now. If we stick with one methadone prescription form, then your answer is there. If the prescription is written on the maintenance form, then it's for maintenance. The pain will have to be on the regular controlled prescription. This session is only for maintenance. We all know as well that PharmaNet has a system in place where a prescription will be rejected if the prescriber does not have an exemption to prescribe methadone. This section of the guide has been changed. The name has been changed. It used to be preparing and storing methadone, but now we're not going to be preparing anything. But this is to address the accuracy of the device that must be used in measuring methadone as of February 1st. The accuracy will have to be at 0.1 mil. 0.1 mil translates to 1 milligram. All of you know that we're all using the calibrated cylinders now, and if you look at the cylinders at the top, most of them will have a plus or minus 2. So we are going actually to the accuracy of 1 milligram given the smaller quantity. So as a college, we set the standards. So here are your standards. The standard is that you would have to use a device with that accuracy. Just like when you are opening a new pharmacy and you have to get a scale and you look at the requirements and there's a sensitivity requirement to the scale, we don't tell you go buy a brand or another. We just tell you the standard. We have time. Those things will be worked out, and hopefully you'd have an answer of what's out there. But as far as I know, there are products out there that would meet that requirement. As always, any devices you use for measuring methadone or anything that has to do with methadone have to be clearly labeled to make sure that they're only used for methadone. Now, this has to do with air travel. This is not a new thing. It's always been in the College of Physicians guide, but I thought we should address it because we saw some discrepancies out there, so we thought we'll just put it out. So in most cases, everybody, most of you are in the room, would know that the restriction to get on a flight has to do sometimes with how much liquid you have on you. So unless you look like me, this is mostly the only restriction you get. When you look like me, you've got a lot of restrictions to get on a plane. You're very well liked there. But due to that fact, the College of Physicians had a section in their guide that says that if a patient is traveling by air, and if the physician has all the documentation they need to be satisfied that indeed the patient is traveling by air, that they can prescribe the methadone anhydrous, which is what you're supposed to be dispensing is the methadone tablets, not compounded methadone. So most recently, we were getting information about pharmacies compounding methadone and basically weighing methadone powder, putting it in gel capsules and handing them out to the patients. That is unacceptable, and we cannot be compounding something that is commercially available. Due to the fact that this methadone 10 milligram is such a small quantity in mils, the new requirement will be that pharmacies must provide some water to the patient. At the time of witnessing, you would need to give them water to wash out any methadone left in the cup that you'll be giving them. And also, given that it's such a small quantity, there's always a potential that they may cheek it, they may hold it in their mouth. So by giving them water, you're making sure that they have washed down the dose. So you must give the patients water. Take-home doses. The college in the past never had any requirements about individual doses being given in individual bottles, but now, due to the fact that the quantity is so small and it will be much harder for the patients to measure accurately a dose given the 10 milligram per mil, now there's a requirement that all carries must be given in individual bottles. And of course, you would have to find the smallest bottle to match the quantity that you're giving out. This is something that when I was in practice, I only saw maybe once or twice. I don't know how many of you have seen this, but in some cases, the patient is not able to come to the pharmacy. Federally and provincially, the methadone patients must be receiving the dose in person. But in some cases, if the patient has a reason not to be able to come to the pharmacy, a physician may designate somebody as a patient's representative to receive that methadone for the patient. But this designation has to be limited to that time. Cannot be open-ended, cannot be just something here, give the pharmacy this and your wife can pick it up for you. If there is a reason, and again, it's the exception, the physician may issue a note, and that note has to be filed along with the prescription. This goes back again to 71, Professional Practice Policy 71, which clearly says that methadone delivery is prohibited unless, of course, we talked about the physician providing that declaration. So, emergency dosing is an issue that keeps coming up. So let's discuss this, and hopefully we can put this issue to rest as well. We all know that the college has a policy, Policy 31, that says that for continuity of care, a pharmacist may provide a dose to a patient. It does not exclude methadone, but given the nature of the illness we're dealing with and the nature of the drug we're dealing with, pharmacists need to come to the decision of providing an emergency dose or not very carefully. And they need to think about steps to come to the decision, is it appropriate to give a patient an emergency dose or not? Emergency doses lately have been ranging from patients forgetting their prescriptions at home, so let's just give them an emergency dose, patients just showing up and out of compassion, I just give him a dose. We're healthcare providers, you guys. We need to stand up and be who we are, clinicians. So a decision like that cannot be taken lightly. Again, I'm not here to tell you not to do it. I'm saying if you do it, be very careful thinking about how you're doing it, because you're also carrying that responsibility along. So Policy 31 used to be a one-liner that said for continuity of care, a pharmacist may provide a dose. But in methadone, we're saying it's not recommended. Given the fact that methadone has a long T-half, so those are the things that you need to know before you make a decision, should I dose the patient or not? Methadone T-half is 36 to 59 hours in clinically stable patients. Is it uncomfortable? Absolutely. But do we want to be hearing from the physicians that we're actually interfering with patient care by providing an emergency dose? Because this is how some of them feel. is because the patient now relies on the pharmacist to carry him if he misses an appointment. So think about it. Rise to the occasion. That's what I'm saying. If you decide to provide an emergency dose, like everything else, make sure that you can defend it to your peers. If anything goes sideways, ultimately, you have to answer to your peers. So make sure that you can answer those 5 fundamentals. Are you competent in the area of addiction and how methadone works and how long it lasts and so on? And also, are you competent in, do I know that this patient looks stable, that I can take the risk of giving him an emergency dose? Do I have appropriate information to make that decision? Would it be appropriate for me? So if anybody asks me one day, why did you give this patient a dose? Can I defend my decision? Or is it going to be out of compassion? Did the patient consent to receiving the dose? Which I don't think that's a challenge. And if you decide to go into the gray area, you better document your decision and how you got to it. Because if it's not in writing, it didn't happen. So you document it, you notify the physician, and you take responsibility for it on PharmaNet. You do not ask the physicians to backdate prescriptions or to give you a prescription to cover for those doses. You are fully responsible for your decision, and you take responsibility for it from there. Now, as always, there is always a but if. So we said that only methadone commercially available product will be dispensed. But when are we going to be able to compound it? Only if there's a shortage of methadone's commercial product. Then I'm hoping that PharmaCare would be notified that there's a shortage, and then they deal with it from there by issuing a PIN or however they're going to deal with it. But this is the only reason at this point that the group came up with that we would be allowed to compound. Now, if you compound methadone, if you end up having to compound it because of shortage, and only for shortage, you still have to compound 10 milligram per mil. You still have to dispense 10 milligram per mil. So what did we talk about? We talked about the change in concentration to 10 milligram per mil, significant change. I understand that it's something that would make you worry, but I don't know if it's impossible. It's just a change in strength, and you're a very capable pharmacist. Policy 66, the changes. We talked about Policy 71 and how deliveries are prohibited unless a physician determines that the patient has got a mobility issue and they sign the declaration, and nobody else can sign that. We talked about the control prescription form that will only be used for methadone for maintenance. And we talked a bit about the accuracy of the device that you would have to use to accurately measure the methadone 10 milligram per mil, given this much smaller quantity that you'll be dealing with. Here's a list of frequently asked questions that, believe me, we're still getting at the college. What is the difference between prescribing date and start date? Here's the prescribing date, is the day the physician saw the patient. This cannot be dated in the future. Now, if the physician intends for this prescription to start at a later date, they put that in the body of the prescription. Are we allowed to accept out-of-province prescriptions for methadone? For continuity of care, you would. However, you would have to dispense it as 10 milligram per mil. Ultimately, the pharmacist is responsible to make sure that the prescription is authentic and that everything else is legal about this prescription before they accept it. In most cases, patients call ahead, clinics call ahead when somebody's coming from out of province, but we do accept them in BC for continuity of care. Do I have to be present to witness methadone ingestion? Is that a yes? Good. Does the patient and the pharmacist have to sign the bottom of the methadone maintenance control prescription form? Yes. Excellent. Can I accept a methadone prescription on the regular prescription form? No. Good. Settle then. What are the next steps? So as of February 1st, you need to be ready, and this is where when the transition starts, where you would have the two products. This is a very critical time that month because you would have both products running in the pharmacy. There's a higher chance of a mistake, so I ask you to be very careful during that transition. You need to be familiar with the College of Physicians and Surgeons. You need to be, of course, familiar with ours because I didn't cover everything in the guide. You need to complete your declaration on e-services. And if you feel, after what we talked about and after you review the guide, that there is anything that a non-regulated staff can do, then you can educate them on that. Now you know your responsibilities. There they are. Now you take it to the next step. Again, how to do the declaration on e-services, log in, get your password, click on My Declaration, check the box that you have attended a live or an online for the ones that will be attending the online session. Select the session that you've attended, and you're good to go. So here's 3 hours of learning that can be applied to your PDAP, your professional development and assessment. And if you have any feedback, anybody who's emailed this address knows that I respond to this. I review this address and I email and I respond to each and every one. Thank you very much for coming out tonight, and I wish everybody good luck.